Hello. Let me check. Let me check the audio and video, then we'll start the session. All right. All right. So hope I'm audible. Good evening, everyone. How are you people? Hello. All right. Okay. Good evening, everyone. Welcome to today's session of surgery. तो आज का सेशन में what we are going to do, let me tell you. So most of you people have studied general surgery very well, GI surgery very well. I know that for a fact because most of the students tend to ignore two parts of the surgery. I'm fine. I hope you are doing well as well. So now what happens with many students, dear? The problem here is that most of the students study the general surgery very well, okay, and also they will study systemic surgery only GIT part, and they tend to leave out one part of the surgery, that is your urology. तो आज का मेन फोकस होगा all the previously asked question based topics of urology and little bit about general surgery also. Good evening Hare Krishnan. ओके तो बहुत बार होता है सर, एवरी टाइम यूरोलॉजी से क्वेश्चन आता है कि यूरोलॉजी से मोस्ट ऑफ द टाइम ईदर रेडियोलॉजिकल इन्वेस्टिगेशन बेस्ड क्वेश्चन और देयर विल बी वेरी इंपॉर्टेंटली देयर विल बी क्लिनिकली आस्क्ड क्वेश्चंस. ओके, ये बहुत कॉमनली आस्क्ड क्वेश्चन है एंड देयर इज अ मिसकंसेप्शन दैट कि बस we study general surgery and every sub part of the surgery is done. No, not like that. Okay, because most of the time you tend to recall and remember and study the trauma part, abdominal trauma and your thoracic trauma. Okay, and also you tend to study other parts such as the burns, etc., and you leave out the main important things. What are those important things? Such as urology and GIT. So these are actually urology is a smaller system with respect to our FMGE syllabus, bachcho. Okay, it's a very smaller system. Since it is a very smaller system, we tend to leave it out. To study urology, basically it requires 2 to 3 hours maximum. At least 3 to 4 questions will come. There is a possibility. So agar 3 question, if you are getting 3 question in the span of 3 hours, that is a great thing. Okay, so कई लोग सोच रहे होंगे कि some people might be thinking that कि सर कल तो न्यू ईयर है, न्यू ईयर के यू में क्यों इवनिंग में क्यों क्लास ले रहे हो? ओके, सी आपका न्यू ईयर आज नहीं है. ओके, आपका न्यू ईयर कब है? ऑन द इवनिंग ऑफ द एग्जाम. ओके, एग्जाम खत्म करने के बाद दबा के खूब पार्टी करना. ठीक है, आज न्यू ईयर का सेलिब्रेशन लीव इट ऑफ, यू डोंट नीड दैट सेलिब्रेशन. ठीक है, जिनको जितना पार्टी करना है, जनवरी 12 खत्म हो गए, एग्जाम हॉल के बाहर ही शुरू कर लो पार्टी. ओके, दोस्तों को बोल देना कि भाई सब कुछ तैयारी रखना, हम लोग आ जाएंगे पार्टी करते हैं. ओके, बट राइट नाउ डोंट डिवेट योर ब्रेन बाय लुकिंग एट अदर्स. स्पेशली इंस्टाग्राम में ना सब लोग न्यू ईयर करके स्टेटस डालेंगे. किसी और को देख के अपना खुद को मत जलाओ. ओके, you got my point, right? So please understand that new year is 12/1/2025. That will be your new year. Okay, हाँ, किसी और को देख के मतलब अपना कुछ को जलाना होता है ना, ऐसे काम मत किया करो. ठीक है, किसी कोई भी पार्टी करने दो, कुछ भी करने दो. तुम भी बहुत पार्टी किए हो. नाउ इट्स नॉट द टाइम. ओके, लेट्स स्टार्ट ऑफ विद द यूरोलॉजी. इन द यूरोलॉजी ऑल ऑफ अस नो एज वी स्पीक अबाउट द यूरोलॉजी. सो लेट्स go through the anatomy little bit very quickly. So whenever we are looking at a kidney has two regions. One is your cortex, another one is your medulla, right? So this cortex and medulla, whatever the urine is collected, it will go into renal calyces, and urine is stored in the renal pelvis. So which part of the kidney works as a storage unit? Basic anatomy question. Storage part of the kidney. Which part? Storage part of the kidney. Okay, because I want you to remember there are two things to be understood. Filtration part is your nephrons, and your storage part, that will be your renal pelvis. What is that? Renal pelvis. Okay, now this renal pelvis, my dear students, joins with some structure called as ureter. Joins with a structure called as ureter. So the place where ureter and renal pelvis are getting joined now, this is called as PUJ. बच्चों, what is it called as? PUJ, pelvic ureteric junction. क्या होता है? Pelvic ureteric junction. Yarokovic junction, pelviureteric junction, because there is something called as congenital PUJ stenosis. In this place only, what you are going to get, there is a disease called as congenital PUJ, pelviureteric junction stenosis. Okay, stenosis. So pelviureteric junction stenosis will lead to chronic renal failure. If at all not treated properly, it can lead to chronic renal failure. So if you take a section of the kidney, you will find the nephron. So from these ureters, from the kidney, they continue to where? Into the bladder. So in the bladder, we have three openings. We have how many openings? Three openings are present in the bladder. What is that? How many openings are there? Three openings are present in the bladder. What are the three openings we have? That is only your, my dear students, two openings for ureters, two openings for ureter, one ureter from one kidney, another ureter from another kidney, two ureters open into the bladder, and this bladder has a internal sphincter where we also call it as a internal meatus. What is that called as? Internal meatus of the bladder. So sorry, internal meatus of the urethra. So this urethra continues the place where prostate gland is present. We will call it as a prostatic urethra. The next followed by we have membranous urethra. Okay. The next part where it enters into the penis, we will call it as a bulbar urethra. Followed by that we have something called as penile urethra. Followed by something called as penile urethra. So these are the parts of the urethra we have. Okay. All right. Let's continue. Let's start off with the urethra itself. So the first and most important thing, the male urethra is about the length of how much centimeter? 20 centimeter. The diameter is about 6 to 8 millimeter. The most important question they'll ask you is narrowest part of the urethra. Understand, narrowest opening alag hota hai bachcho. What is that? Narrowest opening अलग होता है, narrowest, what is that? Narrowest part of the urethra अलग होती है, narrowest part of the urethra अलग होता है. Okay, so narrowest part of the urethra is membranous urethra. Which urethra? Membranous. The widest one, my dear students, widest one is called as a prostatic urethra. Widest one is which one? Prostatic urethra. Okay, female urethra is about 4 centimeter, diameter is up 4 to 6 millimeter. Okay, then we have a prostate gland. Prostate gland, my dear students, weight of the prostate is about 20 grams and it will have a 5 lobes. So what are the 5 lobes of the prostate gland? Let's see. So here we can see very clearly we have a transverse section, right? So the transverse section, we have one lobe in the anterior side. In the middle there is a opening. Can you notice this? Yes, this opening, whatever is there, that is the urethra opening, my dear students. What is that? Urethra. So anything in front of the urethra is anterior lobe. The lobe which is behind the posterior most is your posterior lobe. The part of the lobe of the prostate which is just behind your, what is that? Behind your urethra is your median lobe, and we have a 2 lateral lobes. So totally how many lobes? 5 lobes. One anterior, one posterior, 2 lateral, and one part of the urethra which is what? Which is a median urethra, which is a median part of median lobe of the prostate. Okay, so let's go to the next one. So in the urinary system we have contrast studies which are done, and यहाँ पे बार question drug of choice, sorry, investigation of choice पूछा जाता है. So I want you to be very well prepared. Okay, so in the urinary bladder we have contrast studies. What is that called as? Contrast studies. So for the upper urinary tract, that includes your, what is that? Kidney and your ureters. To study the kidney and ureters we have something called as IVP. बच्चों क्या बोलते हो? IVP. What is IVP बच्चों? Intravenous pyelography. What is that? Intravenous pyelography. IV, intravenous pyelography. Intravenous pyelography. Now, intravenous pyelography is a which type of investigation? It is a type of anterograde. It is a type of anterograde. What do I mean by anterograde? जिस डायरेक्शन में, in which direction urine flow is present, if contrast also flows in the same direction, means contrast also coming in the same direction as urine, then we will call it as a anterograde investigation. If we send the contrast in the opposite direction as the normal urine flow, normally urine will come from kidney to ureter, ureter to bladder to urethra. So if your contrast also goes from the kidney ureter, from their bladder and into your urethra, then we'll call it as which type of investigation? Anterograde. If at all you send the contrast from penis, send it into the bladder, so it is going in a reverse direction, then I'll call it as a retrograde investigation. Okay, so lower urinary tracts include your bladder and urethra. So for the bladder what we do is that cystogram, and for urethra we do is called as a retrograde ureterogram. What is that? Retrograde ureterogram. Okay, then we have the most important investigation, MCU. So this MCU के trap में बहुत लोग गिरोगे, तो I want you to remember this MCU. MCU is called as micturating cystourethrogram. Micturating cystourethrogram. Sir, what is this micturating cystourethrogram, sir? Micturating cystourethrogram is very simple thing. What we do is, so understand, there is a bladder. Okay, so bladder, followed by that there is a urethra. Okay, so first what we do, my dear students, here, so we are going to take a catheter, go into the bladder. Take a catheter and go into the bladder. After reaching the bladder, you fill the bladder with contrast. Okay, you fill the bladder with contrast. Okay, so if at all we are telling, if fill the contrast, okay, so bladder is filled. So bladder fill होने के बाद क्या fill होगा? Bladder full हो गया. Yes, if bladder is filled, what will be the feeling? Urge to urinate. We ask the patient to urinate also. So we remove the catheter, followed by the putting the contrast. We remove the catheter. After we remove the catheter, my dear students, we ask the patient to urinate. We ask the patient to urinate. Once patient is urinating, as patient is urinating, you take the radiograph. You take the radiograph. So basically, while urinating, if you take a radiography, you call it as a MCU, micturating cystourethrogram, which is also called as yes, widening cystourethrogram. So normally think with the logic, but very carefully think with the logic. So what we are doing, we are asking the patient to urinate. As soon as patient tries to urinate, bladder will contrast. So bladder will contract. So as bladder contracts, normally in a healthy individual, what should happen to the contrast? Contrast should shut up and come into the urethra. Contrast should come into the urethra. Why? Because it is coming in the direction of urinary flow. But instead of that, in some patient, if at all the contrast goes into your, what is that? Ureters. Contrast goes into ureters. So normally while urinating, does urine go to the ureters? No, urine will not go back to the ureter. If at all urine is going back into the ureter, then we know that for sure from the bladder, there is a, yes, there is a backflow of the urine to the ureters. Backflow of the urine to the ureter. If there is a backflow is there, then what do we call it as? We call it as, yes, that is only called as vesico-ureteric reflex. What is that called as? Vesico-ureteric reflex. Vesico-ureteric reflex. So vesico-ureteric reflux, whatever is there, so this is a disease, this is a pathological condition. So for the suspected cases of vesico-ureteric reflexes also, the investigation of choice is the MCU, micturating cystourethrogram. Okay, so please understand, MCU are also called as, it's not for, it's R. It's not for, it's R, vesico-ureteric reflex. Sorry, for vesico-ureteric reflex, sorry. For vesico-ureteric reflex, and also posterior urethral valves. What is that? Posterior urethral valves. What is that posterior urethral valve? In a young males, congenital abnormality in which there is a abnormal valves are present, which will not allow the contrast to come down. That time also we can, if we suspect that disease, which is posterior urethral valves, for both of them investigation of choices, yes, investigation of choices MCU. Now you people tell me in the comment section, vesico-ureteric reflex leads to which disease? Vesico-ureteric reflex leads to which disease? Okay, so let's see. So vesico-ureteric reflex, actually it leads to something called as vesico-ureteric reflex leads to vesico-ureteric reflux leads to, yes, that is only your pyelonephritis, leads to pyelonephritis. Okay, one of the leading causes for pyelonephritis is your, yes, vesico-ureteric reflex, which leads to pyelonephritis. Okay, all right, let's continue to the next one. So let's start off with the congenital anomalies. So congenital anomalies, the first and most important thing we need to understand, absence of a kidney. Okay, so absence of a kidney which will occur means congenitally kidney has not formed. That is only called as a renal agenesis. What do we call it as? Good evening. Very good. Pyelonephritis is absolutely correct. Okay, so now if at all absence of kidney is there, means there is a renal agenesis. There is what? Renal agenesis. There is a renal agenesis. Means the problem is kidneys are not formed, so that is why there is an absence of kidney. So if there is a renal agenesis, so what are the early clinical feature? So in the renal agenesis, there will be a history of which amnios, polyhydro or oligohydro. Come on, tell me. In GIT, I had taught you people. If GI anomaly, polyhydroamnios, if kidney is not there, urine will not form. Urine itself is the amniotic fluid. If urine of the baby is not formed, why? Because kidney is not there, no formation of the urine. So there will be history of oligohydroamnios. Oligohydroamnios. There will be history of oligohydroamnios. Sir, अगर kidney नहीं होता है, kidney itself is not there, urine कहाँ से बनेगा? Where will urine come from? No urine. If there is no urine, no amniotic fluid, so there will be history of oligohydroamnios. हाँ, confuse नहीं होना है, confuse नहीं होना है. Okay. So there can be one more possibility. What is that? Ectopic kidney. So ectopic kidney, what will happen? One of the major causes for ectopic kidney is your horseshoe kidney. But what is that? Horseshoe kidney. So normally kidneys are retroperitoneal, which are laterally located. Instead of that, both the kidneys get fused like this. Both the kidneys get fused like this. So lower poles of the kidney is fused. Lower poles of the kidney is fused. The lower poles of the kidney, if they get fused, then we will call it as, what is that? That is only horseshoe kidney. Okay. Now, whenever horseshoe kidney patient comes to us, so the child will have some history. The question is, what are the clinical features? So sometimes there is no rule that there will always be swelling. There can be swelling or there might not be swelling in the abdomen, but child can be asymptomatic. Okay, but sometimes there can be pain also possible, which are very non-specific. Sir, फिर कैसा समझे हम? How do we answer the question? Look at this one, complications. So what will happen? The urine flow will be impaired. Sir, what happens in in the kidney diseases is especially in this kind of congenital anomalies. So very simple. The child will have recurrent urinary tract infection क्योंकि normal anatomy has been impaired. If normal anatomy has been impaired, automatically urinary drainage will be impaired. The urinary drainage, if it is impaired, automatically the child will have recurrent urinary tract infection and stones. Okay, stones. Okay, all right. So as soon as the child comes with a recurrent urinary tract infection, so we analyze for the urinary tract infection, give the symptomatic treatment. We give the symptomatic treatment. तो फिर करें क्या? So investigation of choice. हमें confirm करना है. You can do for CECT or you can go for IVP. The investigation of choices are CECT and IVP. The best one would be your CECT बच्चों. Best one would be your CECT. We can also do IVP. अगर single best पूछेंगे तो CECT कर दो. After आप what brain को करेंगे? क्या स्क्रोटम को करेंगे या कहीं और करना? हाँ करेंगे abdominal CECT. Okay, initial diagnosis, initial investigation is ultrasound, but you are supposed to do CECT. And if at all you do a IVP, intravenous pyelography, उसके अंदर एक appearance आता है sir. Since both the renal pelvis are coming closer, it will give a appearance called as a flower vase appearance, or also called as a hand joining sign. Okay, so this is a very very important direct question. बहुत बार पूछा है. What is the appearance of horseshoe kidney in your, what is that? In your IVP, that will be your flowers appearance. Now the most important part, सब लोग ट्रैप में गिरेंगे यहाँ पे. So what is the treatment? Treatment करना क्या चाहिए सर? हाँ बताओ. Very good, hand joining is correct. See, renal agenesis can occur as a result of AC inhibitor. Yes, possible. Even oligohydroamnios also occurs. Okay. Yes. Now listen to me. अब क्वेश्चन क्या आता है सर? ट्रीटमेंट करे तो करे क्या? हाँ करना है. क्या करना है? ऐसा बीच में इसको फाड़ दो, है ना, सेपरेट कर दो, करोगे? अरे सेपरेट करो, सेपरेट इट, put it in their location and say bye bye. Can we do that? Come on, tell me, can we do that? So antibiotics and stone removal यहाँ पे तो लिखा हुआ है सर, मेरा क्वेश्चन ये है कि उसको काट के अलग कर देंगे, सही रहेगा? Remember this rule, sir. They remember this rule. Never separate. Never separate the kidneys. Never separate them. Never separate them. Separation is not at all allowed. If you separate them, what can happen? There is a problem. The problem is there might be blood vessels running. You cut the kidneys into two halves, and if you cut down the blood vessel, one kidney might undergo necrosis. So no division of isthmus. No division of isthmus is never separate the isthmus is the most important point to be remembered in this particular trap. Trap वहीं पे बनाएंगे आप लोगों को सब कुछ, everything they'll give you flower was appearance. Which of the following is most suitable for this patient? Do a CECT. Most suitable for this patient except full history is given, image of the flower was appearance is given, and all of the following are most suitable except option A. Option A antibiotic, option B CECT for investigation of choice, ऑप्शन सी रिमूव द स्टोन, ऑप्शन डी दे देगा, क्या दे देगा? ऑप्शन डी दे देगा आपको सेपरेट द isthmus. द आंसर इज सेपरेट द isthmus. अच्छा आई सी, हाँ बस किसी को सेपरेट मत किया करो बच्चों, बहुत बहुत गंदी बात होता है वो. चलो यहाँ पे देखते हैं आईवीपी. आईवीपी, सो इन द इंट्रावेनस पाइलोग्राम सर, यहाँ पे क्या है ये? दिस इज ए नॉर्मल इंट्रावेनस पाइलोग्राम. सो इन द नॉर्मल इंट्रावेनस पाइलोग्राम, टू एनालाइज द नॉर्मल इंट्रावेनस पाइलोग्राम, फर्स्ट यू नीड टू अंडरस्टैंड बेसिक्स सर. ओके, हाँ फिर मोय मोय हो जाएगा. ओके, नाउ लिसन टू मी, कैन यू सी दिस? दिस इज योर रीनल पेल्विस सर. दिस इज योर रीनल पेल्विस. रीनल पेल्विस से कॉन्ट्रास्ट चलते 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 कहाँ आ गया? ब्लैडर में आ गया. Okay, from here also, from the renal pelvis, contrast has reached the bladder. So all this way we should be able to look at, what is that? We should be able to look at the ureters also. क्योंकि अगर मान के चलो, let's imagine ureter has been closed down here. If ureter has been closed down here, will the contrast come from this side? From this side it won't come. Okay, only contrast will come from the opposite side. Okay, if one ureter is closed, still contrast will reach the bladder. Contrast will still reach the bladder, but from where? From the another side, from the healthy side. Okay, now when we look at here, this is one of the appearances which looks approximately like a flower vase appearance, where the both of them has come closer. Renal pelvis pass aa jate. The renal pelvis, as it comes closer, it gives an appearance of flower vase or hand joining sign, and this hand joining sign have been asked many times, so be prepared with it. Let's go to the next one, polycystic kidney disease. Polycystic kidney disease, as such, urology from surgical aspect of view, very less likely to be asked, but the point here is that this polycystic kidney disease associated problems can be asked from medicine also. Okay, so let's look at each one of them. So the polycystic kidney disease is divided into two types. One is called as congenital and another one is called as infantile. One is called as congenital and one more is called as infantile. This congenital is also called as adult type bachcho. It is also called as adult type. This can be called as the childhood type. Okay, and from pathology directly they will ask you the inheritance. That's a very important point. Okay, so when we are looking at a congenital or a adult type is a autosomal dominant. Which one? Autosomal dominant, while infantile type is a autosomal recessive. And remember this one particularly, which chromosome has the mutation. For the adult type, the chromosome which has the mutation is on the 16th chromosome, my dear. On which chromosome? 16th chromosome. While infantile type is the mutation is present on the 6th chromosome. Mutation is present on the 6th chromosome. Okay, sir, how to remember this? So adult ho gaya, adult type. Okay, infantile ho gaya, child type. So child is the more recessive than adult. मतलब adult is dominant. तो याद रखो adult का dominant हो गया, तो autosomal dominant. चाइल्डहुड इज द लिटिल लेस डोमिनेंट देन ए अडल्ट, तो इसका याद रखो रेसेसिव हो गया। एंड अडल्ट बड़े होते हैं, बिगर पीपल अडल्ट्स आर सो 16th chromosome, if children are smaller people remember it as 6th chromosome, that's sir. Okay, now when we are speaking of adult polycystic kidney disease, which will manifest usually after 30 years of the age, okay, after the third decade of their life, they will have. And always remember, both of these diseases means adult type and infantile type, both of them are bilateral, means which involves the both kidneys. It can be associated with cyst in other locations. Cyst in other location means if there is a cyst in the kidneys, there is a possibility that they can have cyst in the liver, pancreas, spleen, okay, ovary also possible. And they have two diseases which are associated diseases, okay, mitral valve prolapse and Berry's aneurysm, means these people are more prone to developing mitral valve prolapse as well as Berry aneurysm, okay, no problem. लेट्स गो टू द नेक्स्ट वन। नेक्स्ट वन क्या होता है, दैट इज सर करें तो करें क्या, ट्रीटमेंट करेंगे क्या? सो सिंपल एज दैट, ये इतना बड़ा फूल जाता है। रिमेंबर दिस पॉलीसिस्टिक किडनी डिसीज, इन आई हैव सीन वन पेशेंट, abdomen is swollen so much which looks like a mild forms of ascites। ascites में abdomen सूज जाता है ना, वैसा mild forms of ascites जैसा उतना बड़ा हो गया किडनी। Okay, so what is cyst? Cyst is a cavity covered with fluid. So the patient will have cysts because of this multiple cysts present all over the kidney. So there will be swelling, but so there will be, what will be there? Swelling will be there. Patient can have pain due to what? Pressure on the other organs possible. The patient can have hematuria, okay, and hypertension and uremia. Uremia will not be present initially. As the cyst will start to grow bigger and bigger, normal healthy tissue will start to reduce. As the healthy tissue will start to reduce, uremia will start to prevail, and there will be impairment of the blood supply that will activate the RAS system. Which system? RAS system, क्योंकि ये सारे जितने cyst होते हैं, because of this cyst it might impair the blood supply to the healthy tissue that will activate the RAS system, which leads to hypertension. And it is not mandatory they will have hypertension, but they have a high possibilities of developing, and many times most of the patients will have it, okay. So first clinical approach, कोई भी abdomen में swelling लेके आए, okay, patient is stable, okay, patient is stable, vitals are stable, abdomen में swelling है, सीधा करेंगे क्या? Send him to USG, and investigation of choice is CECT, but they will ask the appearance, and this is asked very frequently. What is that? In the intravenous pyelography, it looks like it has been compared to a leg of the spider. It has been compared to a leg of the spider. So spider leg appearance will be there. And what is the treatment, my dear students? Treatment is very simple to understand. So we can go for something called deroofing of the cyst. But again, even if you try to remove the cyst, हमारा दिमाग बोलेगा सर cyst है तो नीडल डालो, एस्पिरेट करो, ओके, तुम एस्पिरेट करो फिर से भर जाएगा, you aspirate it, it will get filled again, okay. So deroofing of the cyst can be considered, and cyst drainage, incision and drainage, IND, हमारा दिमाग ना बहुत खराब चीज है ये, उस दिन बहुत नया नया तरीका बताएगा, ओके। सो कहीं पे पानी भर के काट के निकालो, anywhere fluid filled, cut it open and remove it, you cannot do that, sir. So no IND, first thing, no IND, there is no IND for your polycystic kidney disease. Best treatment is renal transplant. अगर किडनी ऐसे बाजार में मिल जाएगा क्या? Do you get the kidneys like on the street? Is it possible? No. So what to do? बोल दो, go get lost, go bring your own kidney, then we will put it to you, ऐसा बोलोगे? तो renal transplant से पहले my dear students, dialysis. What is that? Dialysis. What is that? Dialysis. Why dialysis? Because kidney function को replace करना है. Okay, that's it. Exactly. Dialysis followed by renal transplant. Okay. Sure. Sir, let's go to the next one. Congenital anomalies of upper urinary tract. Upper urinary tract. Yes, dialysis is absolutely correct answer. Okay. Now let's go to the next one. So there is a lag, my dear students. मतलब मैं अभी बोल रहा हूँ तो 5 सेकंड के बाद आपको आ रहा है. So because of that थोड़ा बहुत communication gap आ जाता है. फिर भी लगे रहो. ठीक है. चलो let's go to the next one. Lower urinary tract तो पढ़ लिए. Let's go to the upper urinary tract. A few of the a few of the congenital anomalies. So one of the most important one is that is called as duplication of renal pelvis and ureter. Okay, now please understand duplication of renal pelvis. What is that? Duplication of renal pelvis. Okay, so this duplication of renal pelvis surgery, it can be with the duplication of ureter. Possibility number one, it can be with the duplication of ureter. Okay, or possibility number two, no duplication of ureter. Both are possible. No duplication of ureter is also possible, or without ureter duplication. Both of them are possible. Okay, चलो फिर क्या होता है यहाँ पे देखते हैं. So we have one renal pelvis up here, one more renal pelvis down here. So there are congenitally two renal pelvises. Congenitally there are two renal pelvises. So now I want you to understand. So this upper ureter, if at all, if it progress into ureter, this ureter will come, my dear students, and this ureter will go into the bladder proximally or distal to the lower ureter. Tell me, ये जाके bladder को innervate कर रहा है. It is innervating the bladder. Though it is upper ureter always innervates distal to the lower renal pelvis. Lower duplicated part से distal में ये होता है. Now is it a normal location or an abnormal location? Abnormal location. Why? Because normally ureter has to open in the trigone. Okay, in that trigone. But one more ureter is opening in a abnormal location. Since it is opening in an abnormal location, surgery, so if there is a duplication of ureter, so duplication of ureter बच्चों will lead to ectopic ureter. It will lead to ectopic ureter. Okay, ectopic ureter. ये ectopic ureter कहीं पे भी जा सकता है. Ectopic ureter can come and innervate at the level of urethra. If it innervates at the level of urethra, urine रुकेगा नहीं भैया, रुकेगा नहीं. Okay, so what will happen if it goes and ectopically innervates at a level of urethra? Then continuously urine will go into urethra. From urethra it will start coming. So there will be urinary incontinence. Will be there. Okay, now because of this one, this lower part of the renal pelvis, it creates an appearance called as drooping lily sign, called as drooping lily, as if lily flower is drooping like this, called as drooping lily sign. And again, this is a previously asked question. What is that? Drooping lily sign is seen with which disease? Duplication of renal pelvis. So यहाँ पे देखो sir, this one in this image which I am marking now as a star here in the red color. In this image we have, what is that? Renal pelvis has been drooping, and drooping renal pelvis is there, but only single ureter surgery. So there is no duplication of ureters. But यहाँ पे देखो sir, here there is a duplication of ureters is there. And sometimes what can happen, this duplicated ureter fellows, these fellows both can fuse together sometimes. That is also possible. So आपको पूछेगा drooping lily sign क्या है? ओके, किस डिसीज में दिखता है और इसका कॉम्प्लिकेशन हो सकता है. इट कैन बी विद डुप्लीकेशन ऑफ यूरेटर. इफ इट इज विद द डुप्लीकेशन ऑफ यूरेटर, द एक्टोपिक यूरेटर इज द consequence which we are going to face further. So let's go to the next one, duplication of ureter. So usually ureters will join, both the ureters usually join. Rarely they do not join. When they do not join, as I have already explained, so upper ureter pass distally and open more medially. So this is only called as ectopic ureter. This rule is called as Mayer-Rate law. अगर कहीं पे भी हमारा किस्मत खराब हो गया, एग्जामिनर अगर कुछ घर पे लड़ाई करके आपका पेपर बना दिया, तो पूछ लेगा कि Mayer-Rate law is applicable for which of the following diseases. अरे भैया हमें तो पता है ectopic ureter, कोई डर नहीं. That's it. Okay, so if at all there is a ectopic ureter, means abnormal location, if it goes, so where it will go? It will go into the prostatic urethra. Okay, so ureter, see, normally understand, this is your bladder, right? This is your prostatic urethra. Then there is your membranous urethra. Okay, so this is your prostatic urethra. At the level of prostatic urethra, what is happening? That extra whatever ureter was coming, it will come and innervate. Once it will come and innervate, sir, what will happen? continuously it will bring the urine and urine will start flowing. So that will lead to continuously dropping or dribbling incontinence. Which incontinence? Dribbling incontinence. In prostatic urethra, if it is there, in male more commonly prone to UTI, in the female it will be dribbling incontinence. And यहाँ पे याद रखो, these diseases will not manifest in the adult. They will come as childhood. The parents will bring the baby saying that this is the problem, okay, because they're congenital anomalies. Investigation of choice is IVP. Sir, यहाँ पे why not we do the CT? Why don't we do the CT? Because see, here we need to study the anatomy. To study the anatomy, contrast based the basic investigations will also do the trick. So the investigation of choice is IVP. But यहाँ पे you don't cut the pelvis, you don't do anything, just re-implant the ureter. Okay, ureteric re-implantation would be sufficient. Okay, re-implantation, that's a sufficient treatment we can do. Okay, let me continue to the next one. बाप रे, ये तो favorite question of examiner, favorite, that is your ureterocele. Sorry, ureterocele. Okay, ureterocele. Sir, so drooping lily always means abnormal insertion of ureters irrespective of duplication of ureter. No, reverse बोल रहा हूँ. Drooping lily means always it just indicate duplication of renal pelvis. Okay, if there is a duplication can be with or without the duplication of ureter. Ureter duplication is not mandatory, bachcho. Ureter duplication is not mandatory. Okay, ectopic ureter is not a mandatory. It can manifest as a ectopic ureter, but any duplication is there, you are going to find drooping lily. कोबरा हेड, यस, कोबरा हेड. ये कोबरा हेड में ना, अगर मैं एग्जामिनर हो तो सिंपल सा फंसा देता हूं आप लोगों को, ठीक है. तो व्हाट हैपेंस हियर इज दैट, यहाँ पे देखो पैथोजेनेसिस इज वेरी इंपॉर्टेंट, जो जिसको हम लोगों ने दिल खोल के इग्नोर कर दी. लेट्स इमेजिन दिस इज ए ब्लैडर. ओके, अगर किसी ने पढ़ लिए तो मुझे मत डांटो भाई, पढ़ लिए वो अच्छी बात है, ठीक है. लेट्स इमेजिन दिस इज द ब्लैडर का वॉल. Okay, let's imagine this is the bladder cup wall. Okay, so in the bladder cup wall, so we have outer layer, we have muscular layer. Okay, we have which layer? Muscular layer. Okay, that is detrusor muscle. Okay, then you have your epithelium. You have your epithelium. Okay, now what happens in here is that, so this place what will be there is, see, there is a small opening. There is a small opening. Okay, there is a small opening, means the opening which is present for the sake of ureters to open, means ureteric orifice. Ureteric orifice is partially atretic. Atretic means absence of formation, because of which ureter ऊपर से आएगा. Okay, now once ureter comes here, the problem is the opening is very small. Since the opening is very small, within the walls of the bladder, it will start to dilate, because the opening is small. Automatically within the walls of the bladder, intramural means within the layers of the bladder, the ureter has been dilated. So dilated structure को बोलते हो seal. So ureterocele, because of what? Partial atresia of ureteric orifice. Dilation कहाँ पे है? Within the layers. Okay, ये बहुत important key point है to understand. Okay, so within the layers of the bladder, so in the layers of the bladder, so intramural dilation of your ureteric orifice leads to ureterocele. So usually it is bilateral. It's more common in female patient. So again, orifice तो है, मतलब opening is there, but very small opening. So urine will be coming, but more urine we cannot come out. So more urine start to store up here and it starts to create the urinary tract infection. So again they'll come back with a, what is that? They'll come back with a, this one. What is that? That will be urinary tract infection. Investigation of choice MCU nahi bachche, IVP, intravenous pyelogram, IVP. That is that. Yes, this video is enough for all the parts of urology. Definitely I can tell you. Because आप लोग तो जनरल सर्जरी वगैरह अच्छे से कर लिए होंगे. ओके, जो सब्जेक्ट, सी माय स्ट्रेटजी इज वेरी सिंपल. जो पार्ट ऑफ द सब्जेक्ट व्हिच स्टूडेंट्स टेंड टू लीव इट एंड गो, दैट पार्ट आई वांट टू मेक इट स्ट्रांग. ओके आदित्य, Anyways, investigation of choice is your IVP. IVP के अंदर क्या दिखेगा? एडर हेड, कोबरा हेड अपीयरेंस, और बहुत बार पूछा गया एडर हेड अपीयरेंस. यहाँ पे देखो देखो देखो, you can find adder head appearance and at the level of urinary bladder. So that is your IVP's adder head appearance or cobra head appearance. We will call it as a ureterocele. Sir, अगर पूरा सब कुछ दे दिए लोगों ने, if they give everything and ask us to what is the treatment? Treatment is very simple. Take an endoscope. गो इनटू द ब्लैडर. सर एंडोस्कोप तो मुंह में डालते हैं. अरे भाई ध्यान रखो, अगर किसी को कंफ्यूजन है तो एंडोस्कोप is a generalized term which is used if at all you are passing a camera through a natural opening in the body. We will call it as a endoscopy. But if you are doing that endoscopy for a bladder, see, sir, 2 घंटे में major parts of the urology I have covered. Already there is a video about GIT and other parts of the surgery. Aditya, एक बार चैनल पे चेक कर लीजिएगा, मैंने ही पढ़ाया. ठीक है सर, चलो. Now what we are supposed to do is that take a cystoscope or a endoscope. It is the same meaning. Cystoscopic or endoscopic orifice cutting down. Okay, so endoscopic incision of ureteric orifice. बच्चों, endoscopic incision of ureteric orifice. Ureteric orifice. Okay, so ureteric orifice को cut open करोगे तो patient will become normal. So that is only endoscopic. Yes, endoscopic resection of the ureteric orifice. Okay, so that finishes your which one, sir? That finishes your ureterocele or a partial atresia. Okay, let's go to the next one, posterior urethral wall. Again, posterior urethral wall also very frequently asked question. Let's go into that topic. Posterior urethral wall, it occurs only in the male children. It occurs only in the male children because in female it is less likely to happen because their length of the urethra itself is short. The length of the urethra itself is short. That's why. So let's start off with the posterior urethra. So what happens here is that, so if you consider this is the bladder. Okay, from the bladder your urethra is coming, right? So it's more common or only in the male, right? So let's see. So urethra is coming like this. Now normally there is no valve in the urethra. There is no valve in the urethra. So if there is no valve in the urethra, now what happens, Sergi, here? So there is an abnormal valve formation will be there. So valve will work like this. Okay, normally what will happen? It will be sitting like this. So as soon as bladder contracts, the valve will shut down. As soon as bladder contracts, the valve will shut. If the valve shut down, urine cannot come out. So this is the most common obstructive lesion of the urethra. Okay, the most common site is there is a point called as verum montanum, just distal to verum montanum. Just distal to verum montanum is the most common site. Okay, now the problem here is that, sir, if at all there is an obstructive lesion, the child will not be able to urinate. So इसके अंदर दो तरीके होते हैं, partial, what is that called as partial, and one more is there, sir, complete. Partial and complete. So if at all we are speaking of partial, तो इसमें क्या होता है, valve is there but not completely formed. So if partial is there, child will urinate or not urinate? Urination is present. Okay, so if urination is present, then what is the problem here? If it is a partial, तो मतलब valve is there, वो completely बना नहीं, तो urine तो pass होगा, but not very well urination. Okay, so if there is no very well urination, so the child will have complaints in the partial type. There is a complaints of recurrent UTI, urinary tract infection, and इसी के अंदर ये सिर्फ और सिर्फ partial में. Okay, so slow stream urine होगा, सिर्फ और सिर्फ partial में there is the appearance called as keyhole appearance. What is that? Keyhole appearance. Which appearance? Keyhole appearance. मतलब छोटा सा छेद जैसा. There is a hole for the key, like that appearance can be seen in partial, but in complete type, so there is the valves are closing the urethra. If valves are closing the urethra, urine will not come down. If urine will not come out of the bladder, so urine will start to retain in the body. So in the complete, what will be there? No urination after birth. And again आप लोग मुझे बताओगे which type will be there, whether it will be, what is that, whether it will be a oligohydroamnios or polyhydroamnios. There will be history of oligohydroamnios because urine is not coming out. So in all the renal disabilities, there will be history of oligohydroamnios. In all the in all the GIT disabilities, there will be history of polyhydramnios during the pregnancy. Okay, so it can be complete or incomplete. Completed investigation is your MCU, mutating cystourethrogram, are also called as voiding cystourethrogram. Correct, correct, absolutely. Oligo is the correct answer. Then we have the treatment what you are going to do. So you are going to go via urethra and you are going to cut those valve. Okay, so this is only called as a trans urethral what is that? Resection of valves. Resection of valves. Transurethral resection of valves, which is also called as fulguration of the valves, which is also called as fulguration of the valves. Okay, so this is the story of your, which this is a posterior urethral valve. Again, commonly asked question. Again, commonly asked question. Let's go to the next one, hypospadias. Okay, so now what happens in the hypospadias? So hypospadias, I will give you people a overall generalized idea so that people won't fall into trap. Which is the most complex, which is the most easier to treat, what is the treatment? Let's talk about everything. Okay, all right, what exactly happens? So in a normal penis, as you can see, urethra is opening at a glans penis, at the tip of the glans penis, right? At the tip of the glans penis. Now what will happen in some children? There is congenital anomaly in which what happens, this urethra opens just below the glans penis. Means if this is the penile shaft, below the penile shaft, urethra was supposed to open at the tip of the, yes, tip of what? Glans penis. Instead of that, it is opening in the lower part of the penis. Okay, so once it opens in the lower part of the penis will start to curve like this. So curved penis, we will call it as chordae. Okay, curved penis, we'll call it as chordae. Okay, अब दिमाग कहीं और मत लेके जाओ. Curved penis, which is a permanently, like it is a permanent curvature which can be treated, So if there is a chordae, that is called as downward curvature of the penis. Okay, so there is a abnormally coming way. Which one? Opening is which one? Abnormally in the lower part it is opening. What we call it as hypospadias. Okay, so what we are going to do is, my dear students, so most importantly, don't advise the patients. If at all some parents, because of some religious purpose or something, if they want to do the circumcision, do not let them do the circumcision, because we will require that, yes, profuse, because during the circumcision we are going to remove the profuse, right? So yes, I will zoom, don't worry. As of now you can see, right? Cardi and all understood now. Okay, now listen to me, what exactly I'm telling. So chordae means downward curvature. So we are not supposed to tell the, we are supposed to guide the patient, don't do the circumcision, because that profuse itself we will use. So what we are going to do is that, so we are going to do ureteroplasty, use the profuse and do the treatment, use the profuse and reconstruct the urethra. So that is only called as ureteroplasty. Okay, that's why circumcision we don't allow the patient, because if at all circumcision is done, so profuse is removed. If profuse is removed, we don't have any tissue left out for the, yes, reconstruction. Okay, so if at all you do a reconstruction, there can be complication. That is post surgically there is a complication called as ureterocutaneous fistula can develop. Ureterocutaneous fistula. Okay, I hope you understood. Let's continue. Undescended testis. अनडिसेंडेड टेस्टिस के बारे में बहुत इससे पहले क्वेश्चंस आया हुआ है. Okay, let's understand. Okay, so undescended testis gives rise to cryptorchidism. Okay, मतलब क्या होता है? Testis are formed in the abdomen. They go down, they enter the inguinal canal. From the inguinal canal they will enter into scrotum. कैसे जाएगा? abdomen से inguinal canal, from there scrotum. Okay, so that is the normal course of testicles throughout the development. But अब क्या हो जाएगा? Now what will happen? The testicles will come from the abdomen. They'll go down. They'll get stuck in the रास्ते में अटक जाएगा. They'll get stuck in the, for example, inguinal canal. If they get stuck in the inguinal canal, scrotum खाली. Okay, scrotum khali. Why? Because testicles have not come down, right? So they are hidden. So if something is hidden, crypto means what is that? cryptorchidism, that is hidden testis, that is can give rise to hidden testis. The testis is there, okay, लुका छुपी खेल रहे, ठीक है, so hide and seek they are playing, okay. Now what exactly I'm trying to tell you is they are getting stuck into your what, stuck in the inguinal canal. Most common place to get stuck is inguinal canal. Now if they get stuck, so arrest in the path of the descent, they will create a so now testis is located in the abnormal location, so we will call it as a ectopic testis, okay. Now complications are very important. If at all undescended testis is there, if at all proper treatment is not done, if proper treatment is not done, they can give rise to, one is देखो यार inguinal canal, ऐसा है inguinal canal, so testicle got stuck here. So as testicle got stuck here, now what can happen? Blood supply is reduced and they're not doing their normal function. Any structure if not used in the body, what will happen? कोई भी स्ट्रक्चर अगर बॉडी में ज्यादा यूज नहीं करोगे तो क्या होता है? What will happen to it? If any structure you don't use it in the body much, what will happen? अरे यार तुम्हारा दिमाग कहीं और मत लेके जाओ, okay. Normally I'm talking about muscles, okay, muscles, blood vessels, that's it, okay. Not even blood vessels, I'm speaking of muscles, okay. What will happen? They'll undergo atrophy, shrink in the cell. The same thing can happen to the testicles, because here atrophy is not because of the not usage, so not because of not using the testicle, rather it is because of the abnormal location will not allow the testicle to grow, because enough space is not there and enough blood supply is not there, okay. So that is why it lead to atrophy. And because they are stuck in the inguinal canal during some physical activity or something, they can undergo trauma, okay. And there is one more possibility, inflammation of epididymis and testicles called as epididymoarthritis. And if at all if it is bilateral, अगर कुछ नहीं करेंगे तो person can develop what is that, sterility, okay. Then there is one more possible, what is that, torsion of the testicle, matlab testicle can get twisting of the testicles, okay. And one more thing is inguinal hernia, because they're getting stuck in the inguinal canal, so they can give rise to inguinal hernia. And there is one more possibility called as seminoma, that is a tumor which originates from the, not from the semen, from the testicles, okay. Now first thing करोगे क्या, अगर पेशेंट आएगा तो सीधे यूएसजी भेजोगे या ढूंढोगे भैया कहाँ गए, मतलब यू डू ए क्लिनिकल एग्जामिनेशन फर्स्ट, ओके. सो स्क्रॉटम के लिए यू डू ए normally physical examination. After following the physical examination, you send the patient to the ultrasound, okay, if at all anything else is there, okay. Then investigation of choice, my dear students, that is your diagnostic laparoscopy, okay, not endoscopy, diagnostic laparoscopy. कैमरा डाल के ढूंढो, अरे भैया कहाँ छिपा हुआ है तू, okay, where are you hiding, like that you got to find out. So you put a camera into the abdomen and search. So what do we call it as? Diagnostic laparoscopy. And followed by that, the treatment will be archidopexy. You cannot leave it there like that, you are supposed to do the surgery. So one of the congenital anomaly जिसके अंदर mandatory surgery require हो रहा है, one of the main diseases is undescended testis, okay. Let's go to the next one, trauma to the lower urinary tract. Again this was asked previously, okay, बहुत बार पूछा गया, ठीक है. चलो अब समझते हैं trauma to the lower urinary tract, okay. So what exactly is there? That is your bladder rupture, sir. Bladder rupture होता क्या है, कब होता है, कैसा होता है, let's understand everything, okay. Now normally bladder anatomically ये पेरिटोनियम से बाहर है, anatomically it's extra peritoneum. Anatomically where it is located, extra peritoneum, okay. That is normally empty bladder. See, normally we wait for few months, okay. 6 to 7 months also we'll wait. Sometimes we can wait up to 3 years of age. This is a controversial information. So we wait, followed by waiting only. So immediately at the birth the surgery nahi karo. Immediately at the birth you are not going to do the surgery, okay. You are going to wait for the descending, okay. Followed by the descending only you are going to do the surgery, okay. Chaliye sir. Normally which one? Empty bladder normally extra peritoneal. पर क्या होता है, आज क्या है, न्यू ईयर का ईव है, कल तो न्यू ईयर है, तो न्यू ईयर का रात को पार्टी करेंगे लोग, ओके. आज तो ऐसा होने का संभव बहुत ज्यादा है, Okay, so what will be there? So normally empty bladder is extra. Okay, रात को करेंगे क्या सर? लोग जाके क्या करेंगे? Not सब लोग, many people go drink alcohol. So there is particularly beer drinkers. When they drink beer, there is a excessive urination. There is a excessive urination. So bladder full हो जाएगा. So bladder full हो जाएगा. वो भी full, bladder भी full. अगर full bladder, if there is a full bladder, okay, if there is a full bladder, then what will be there? So this full bladder that time, it is both extraperitoneal and also intraperitoneal, because वो stretch हो जाएगा, bladder will become intra. So intraperitoneal rupture occurs followed by mainly occurs by injuries after injury followed by beer drinking. Okay, followed by beer drinking, what will be there? Excessive. So excessive, what is that? Beer drinking, excessive filling of the bladder. So now it is a intraperitoneal that extraperitoneal usually associated with pelvis fracture. Okay, pelvic bone fracture हो गया या hip bone fracture हो गया. During that time you are going to get extraperitoneal rupture. Okay, extraperitoneal rupture. Now, if there is an intraperitoneal rupture, कब होगा? Trauma to the over-distended bladder, that is only after drinking, and also lower abdominal surgery is possible. Okay, so clinical feature, bladder कहाँ पे होता है? Bladder is located in which quadrant? It is located in the hypogastric region. Which location? Hypogastrium. Where is it located? Hypogastrium. So in the hypogastric region, so the patient will start to develop a severe pain. So sudden severe hypogastric pain, and patient will have severe irritation of peritoneum. Even there can also be loss of consciousness called as syncope. So the patient will have sudden severe hypogastric pain with a syncope. This is a common presentation of the patient with urinary bladder rupture. Okay, so blood side test करेंगे peritoneal tap मतलब so usually ultrasound guided prefer करते हैं. So you are going to go into the peritoneum and try to take out the fluid. When you take out the fluid, अब अगर bladder if it is ruptured, पूरा peritoneum में कौन leak हो जाएगा? Who will be leaked? Urine will be leaked. If urine is leaked, automatically you can find it in the peritoneal tap. So if you find urine in the peritoneal tap, that is suggestive of bladder rupture. Okay, investigation of choice, cystogram. Investigation of choice is cystogram. Okay, now cystogram के अंदर क्या होता है? Listen to me. Contrast, bladder के अंदर रहना चाहिए. Contrast should remain in the bladder. Contrast should remain in the bladder, but contrast will start to leak out of the bladder. If contrast is leaking out of the bladder, that is very clear. There is a hole in the bladder. So if there is a hole in the bladder, that is only called as ruptured urinary bladder. So the treatment will be laparotomy. Open the abdomen fully. Do the peritoneal lavage. Okay, normal language में, like in normal language, it's like grooming and mopping, like that only. You are supposed to clean the whole peritoneum, followed by that bladder repair करो and drainage डालो. Very important, drainage तो डालना ही डालना है सर जी. Drainage तो डालना ही डालना है, because if you don't put a drainage, urine will start to get accumulate. जहाँ पे आप repair किए होंगे, where you have repaired, that area will start to tear up once again if you don't put a drainage. So you need to put a drainage. Along with that, you are going to do the bladder repair. So cystogram will be the investigation. There is a teardrop bladder appearance. There is appearance called as teardrop appearance. Okay, then let's go to the next one, urethra rupture. So the next one, urethra rupture. So urethra rupture, my dear students, it can be of two types: anterior urethra rupture or posterior urethra rupture. Okay, so which part? Anterior urethral rupture involves the perineal and bulbar part of the urethra. Okay, मतलब जो सामने के तरफ. Okay, so it is perineal region. So if it is that is the scenario. So perineal urethral rupture कब होगा? Associated with perineal trauma. Perineal trauma, I will tell you. अगर मान के चलो, let's imagine a person was walking on the road. Somebody did not cover the manhole properly. जो manhole होता है ना, manhole को नहीं properly, it was not closed. Okay, the person is walking. He steps on the manhole. Manhole immediately, instantly split. Like so, immediately person goes and hits. Okay, अब लोग imagine करके दर्द बहुत. Okay, he is walking and going, steps on the manhole. It was not properly closed, but सब मुड़ जाएगा. So suddenly patient will fall. Like as soon as patient will fall like this, automatically manhole will go into the perineum. Manhole will go into the पेरिनियम, तो तुम्हारा बॉडी का वजन पूरा उसी के ऊपर गिरेगा. ओके, सो दैट विल लीड टू व्हाट इज दैट पेरिनियल ट्रॉमा, दैट लीड टू पेरिनियल ट्रॉमा. तो इसी को इन टेक्स्ट बुक्स इट इज डिस्क्राइब्ड एज ए मैनहोल इंजरी, मैनहोल इंजरी. बट भाई हम देसी आदमी है, राइट, वेरी इंडियन, तो हमें और भी कुछ कोरिलेट करने के लिए चाहिए. All of you know there used to be one cycle called as hero cycle, जो rod आता है. So there is a hero cycle with a rod in the middle. You sit and you are pedaling, right? So when you are like standing up and pedaling very fastly, and if there is a problem in the chain, जो bearing गायब हो जाता है, bearing के अंदर balls निकल जाते हैं, ठीक है? So bearing का balls है, दिमाग है. So bearing balls is gone. Now you are standing and going, it will go and hit the rod, but ऐसे ही. Okay, yes, that is also possible. So whenever there is a perineal trauma, so that time the patient will have retention of urine. Perineal hematoma is possible. In that area there is a bleeding and hematoma. Okay, and most importantly, patient when he comes, you can find most important is blood at the tip of the external urethral meatus. What is that? Blood at the tip of the external urethral meatus. Okay, हाँ सबको हुआ होगा. अटलास के वो हीरो साइकिल देखे भाई, सबको हुआ होगा, याद आया कुछ? Okay, now so because there is a injury, automatically through the urine small drops of blood will come. So there is a blood at the tip of the external tip of the penis. Okay, then posterior urethral rupture can involve the membranous part of the urethra, so which is again due to pelvis fracture. Okay, so bladder rupture and urethral rupture both are associated with pelvic fracture. Okay, so most commonly at the apex of the prostate. तो इसमें DRE करोगे तो prostate थोड़ा ऊपर चला जाएगा. Okay, for now remember posterior urethral valve has high lying prostate on a digital rectal examination. Okay, सिर्फ याद रखो, because if I give the explanation it is not worth you wasting your time, that's why. So investigation of choice, bezo contrast, ढूंढो काम पे फटा पड़ा है, where is the tear? So you are going to do a retrograde ureterogram, and most importantly first step करना क्या चाहिए? ट्रीटमेंट करोगे क्या? फर्स्ट स्टेप, अगर ब्लैडर रप्चर भी आया हो या यूरेथ्रा रप्चर भी आया हो, फर्स्ट ट्रीटमेंट करोगे क्या? आरजी वगैरह इन्वेस्टिगेशन ऑफ चॉइस ठीक है, फर्स्ट स्टेप करोगे क्या? अगर सस्पेक्टेड केस आता है तो कैसे मैनेज करें इसको? अरे रिपेयर द डैमेज, रिपेयर डैमेज से पहले अंडरस्टैंड, एक बात समझो, कंटामिनेशन को कम करनी है. फर्स्ट थिंग, wherever there is a wound there can get contaminated, first prevent the contamination, उसके बाद हीलिंग कर लोगे, है ना? सीधा यूरोलॉजिस्ट तो ना बनेंगे. यस और नो? हम लोग क्या करें? सो फर्स्ट स्टेप सर is to place a Foley's catheter. ठीक है, Foley's catheter बाद में रिपेयर वगैरह, ठीक है. Foley's catheter, or also we can do best, Foley's is risky, best one more we can do is suprapubic catheter. Both are used. Okay, so this is the story of your, what is that? So that's the suprapubic cystostomy is later, initially Foley's only. भाई साहब ठीक है, शुरुआत Foley's करो, ठीक है. अगर मान के चलो you are doing internship, ठीक है, cystostomy करने गए, कुछ गड़बड़ हो गया तो, if something goes wrong, right? That's why first Foley's, then under the supervision of expert you can go for suprapubic cystostomy. So the next one is the next most important topic is urolithiasis. Next most important topic is urolithiasis. Yes, then you can go for the urolithiasis. Urolithiasis, my dear students, urolithiasis is a condition where there is a kidney stones are formed. तो इसके अंदर ज्यादा कुछ मतलब समझने के लिए ज्यादा कुछ नहीं है, सिर्फ it is a theory. तो normally urine is acidic. If but all there is a increase of urine pH, that can also leads to urolithiasis. Okay, so the thing is altered urinary solutes. So if there is a decrease of citrates and increase of oxalate, that increases the risk of stone formation. ओके, सो यूरिन कहीं पे भी ड्रेनेज नहीं हो रहा है, जैसे कि कंजेनिटल अनोमलीज हम लोगों ने डिस्कस किए थे, फॉर एग्जांपल व्हाटएवर इट मे बी, लाइक diseases like horseshoe kidney, diseases like other things like your duplication of ureter, duplication of renal pelvis. During this time, inadequate drainage will be there. That can also lead to urinary stones. And most importantly, which important infection causes that? Urolithiasis. That is your proteus infection. Main culprit in developing the risk of your urolithiasis is your, yes, that will be your proteus. Then hyperparathyroidism, because in the hyperparathyroid patients they can also develop what is that? Kidney stones. क्योंकि blood के अंदर calcium ज़्यादा होता है, more calcium in the blood, more calcium enters into the urine, that can also lead to. Then hyperuricosuriia, excessive uric acid in the urine or excessive urea in the urine can also lead to the stones. Okay. Then vitamin A deficiency. How does it cause urolithiasis? Because vitamin A is required. Vitamin A and C, they're mainly required for the healing of the mucosas. Healing of which one? Mucosas. So uska deficiency, maybe there is a possibility. Okay. And one more disease is there. There is a Randall plaque. Randall plaque is nothing but, so there is a damage of the layer of your transitional epithelium, because of which urolithiasis can occur. Okay. Then, so there are types, sir. So the calcium oxalate stone. So calcium oxalate stone, which can be monohydrate type and dihydrate type. Dihydrate is the most common type of stone. Okay. सेकेंड हार्डेस्ट स्टोन इज मोनोहाइड्रेट. ये सारे फैक्ट है बच्चों, तो इसको याद रखना पड़ेगा. ठीक है. सो देन वी हैव वन मोर पॉसिबिलिटी कॉल्ड एज ट्रिपल फॉस्फेट स्टोन. Okay, so triple phosphate stones are associated with alkaline urine. जैसे हो गया कि proteus infection. Okay, now triple phosphate stones develops into a shape called as staghorn stone. Which stone? Staghorn stone. तो यहाँ पे कंफ्यूज मत होना, ये अदरक नहीं है. It's not ginger. It's not ginger. It's a stone. It's not ginger. It's a stone. So stone is becoming exactly in the shape of what? In the shape of renal pelvis. Okay. So if the stone takes up the shape of the renal pelvis, then you call it as a staghorn stone. Which stone? Staghorn stone. Okay. The hardest type of renal stone is your, what is that? Hardest type of renal stone is your cystine stone, my dear students. Which one? Cystine stone. So which ones are the smoothest type of stones, among which that is your uric acid stone. So uric acid stones are not visible on X-ray. Not visible on X-ray. Remember, not visible on X-ray. Why? Because they are radiolucent. मतलब they allow the X-rays to pass through them. तो वो दिखेगा नहीं. Okay, झुकेगा नहीं, दिखेगा नहीं. You will not be able to see. Okay, so gallstones is also a type of radiolucent stones. Gallstones is also a type of radiolucent stones. Okay, now then we have xanthine stone, lysine stone, indinavir, allopurinol, triamterene stones are possible. Okay, तो most common clinical feature, ये बहुत बहुत important है, आप लोगों को याद रखो. ये मतलब मैं लोकेशन के हिसाब से जो है ना, मैं उसको कंफ्यूज नहीं करूंगा, बस इतना याद रखो. पेशेंट विल हैव इंक्रीज फ्रीक्वेंसी ऑफ यूरिनेशन. इंक्रीज फ्रीक्वेंसी ऑफ यूरिनेशन इज a clinical feature of one more thing. What is that one more thing? That is your, yes, clinical feature of your urinary TB. Urinary TB. Then the patient can have hematuria, and patient can have interruption of the urinary stream. That is flow में दिक्कत होता है, धार बनने में दिक्कत होती है, if it is especially present in the urethra. Okay, especially in the bladder and urethra stones, especially bladder stone. Okay, urethra stones usually lead to obstruction. Okay, वो bladder stone urethra में निकल जाएगा. That's it. Now the patient can have next important aspect. ऐसा आएगा तो आप लोगों को ये important aspect है. I want you to remember this particular aspect. What is that? So when the patient comes to you in a severe pain. Once severe pain is there, so first stabilize the patient. Okay, followed by USG is preferred. Initial investigation is USG, but the investigation of choice, यहाँ पे मत फंसो. It is not a contrast. It is NCCT. Why NCCT? Stones तो ऐसे ही white color से दिख जाएंगे. Stones can be seen white color on a CT directly like that. So you do not require a contrast in the renal stones. Okay. So sir, what is the treatment? यहाँ पे जो treatment है ना, ये investigation of choice and treatment are two important parts of the urolithiasis which are commonly asked. Okay. So we have ESW. ESWL, when do we do ESWL? When do we do other things? Okay. If at all stone size less than 2 centimeter, less than 2 centimeter, less than 2 centimeter, correct. Okay, less than 2 centimeter, you go for extracorporeal shockwave lithotripsy. What is that? Extracorporeal shockwave lithotripsy. Okay, for the kidney, ureteric, for both kidney and ureteric stone, if less than 2 centimeter, you go for, yes, ESWL. If it is more than 2 centimeter, you go for PCNL. What is PCNL? Percutaneous nephrolithostomy. Okay, sorry, nephrolithotomy. Okay, so you can go for lower ureteric stones, you can go for URS. Lithoplaxy for the bladder stone, lithoplaxy for the bladder stone. Okay, so more than 2 centimeter PCNL, less than 2 centimeter ESW. Okay, let's get into the next part, that will be your urinary TB, sir. Okay, urinary TB is a very commonly asked question, especially an image based question, बच्चों बहुत बार पूछा जाता है. ठीक है, let's see what happens. So first and most important, urinary TB कैसा होता है, how does it spread? I will explain this scenario, you understand, then we will go for every pathological stages. So normally tuberculosis infection is a type of primary TB of lungs. Most commonly primary TB will be lung TB. Most commonly primary TB which TB? Lung. From the lungs, the bacteria enters into the blood. From the blood, it will start to spread all over the body. It will start to spread all over the body, such as any location, for example, abdomen, for example, meninges. If it comes into the kidney, it will lead to renal TB. So when we are speaking of renal TB, my dear students, first and most important, I want you to understand. So the TB bacteria comes and start to infect the kidney. Though it is infecting the kidney, the bacteria is not found in the urine. So initially, what will happen? It will. I'm sorry. So initially, patient will have pyonephrosis. Pyo means pus in the urine. Pus in the urine, and not specifically pus around the kidney. Pus around the kidney. Okay. Now, so though there is a pus, but no bacteria in the urine. Though there is a pus, no bacteria in the urine. Okay. So now the urinary TB will slowly progress. Urinary TB will slowly progress. As it slowly progresses, so there will be parenchymal abscess, means small minute abscess. Followed by that minute abscess, your kidney will try to heal. Healing will lead to fibrosis. So that will lead to hardening of the kidney, because fibrosed kidney will become hardening of the kidney, which will lead to potty kidney, which is also called as cement kidney. So kidney will become a stone like structure. Look here, this is the bone, this is the kidney. So kidney on a normal x-ray, it is becoming a consistency of bone. So that much calcification has occurred. That much calcification has occurred. So because of this calcification, we will call it as putty kidney or a cement kidney. So once kidney has undergone fibrosis and calcification, so because of this fibrosis and calcification, automatically kidney function is lost, called as autonephrectomy. So putty kidney or cement kidney, which is a hard shrunken kidney which looks like this, and here also you can see kidney consistency has become into the that of a stone. Okay, so ureteric TB is rare, ureteric TB is rare, but if there is a ureteric TB, there is a stricture mainly at which location? Pelviureteric junctions में, pelviureteric junction में stricture हो सकता है. So bladder TB के अंदर, the bladder TB initially, because the bacteria should come from up to down, na? So initially it will seen at a ureteric orifice. Later it will lead to again fibrosis of the bladder called as thimble bladder, narrow contracted bladder called as thimble bladder. So normally TB का symptoms such as constitutional symptoms तो रहेगा ही. Okay, constitutional symptoms will be present. Along with the constitutional symptom, patient can have hematuria and increased frequency, but the patient will have one important point: sterile acidic pyuria. Initial urine examination, sterile acidic pyuria. Sterile acidic pyuria. So investigation of choice will be CECT. So IVP के अगर renal TB में देखोगे, moth eaten calyces, लेट में cement kidney बनेगा, and IVP bladder में क्या दिखेगा? Goal for appearance initially, later it will become into thimble bladder. So what will be the treatment? The treatment will be, my dear students, the treatment will be anti-tubercular therapy, anti-tubercular therapy. So here you can see putty kidney, and here you can see thimble bladder, narrow contracted bladder. Okay, so surgery will be required. Pyeloplasty, Henderson-Haynes operation is required. If there is a, yes, PUJ stenosis. PUJ stenosis के लिए कौन से ऑपरेशन करोगे? पाइलोप्लास्टी, that's called as Henderson Haynes ऑपरेशन. अगर टिम्बल ब्लैडर बन गया, सर टिम्बल ब्लैडर बनेगा तो ब्लैडर तो नैरो कॉन्ट्रैक्ट हो गया, तो निकाल ही दो ना, सिस्टेक्टमी, यू रिमूव द ब्लैडर. सो क्वेश्चन आएगा सर ब्लैडर रिमूव करेंगे, इफ यू रिमूव द ब्लैडर how do we manage? So if you remove the bladder, you are going to create a new bladder. So you are going to create a new bladder using your ileum, neo bladder using the ileum. Okay, so ureteric stricture को क्या करोगे? Ureteroplasty. Okay, so let's go to the next one, that is your prostate के बारे में. Okay, so the most important disease of the prostate which I would like to discuss, my dear students, BPH. Okay, BPH को समझने के लिए first let's understand, in the male we have a hormone called as testosterone. Now this testosterone undergoes the influence of an enzyme called as 5-alpha reductase. So this 5-alpha reductase creates 1,5 dihydroxytestosterone. 1,5 dihydroxytestosterone. So this dihydroxytestosterone goes and stimulates the prostate growth. So that is how it is leading to what is that? Benign prostatic. So when prostate growth occurs, prostate will become enlarged. Once prostate becomes enlarged, understand, ये prostate है. Okay, this is the urethra. So urethra का surrounding में what structure is there? Prostate is there. Now once prostate enlarges, it will start to put pressure on the urethra. So prostate will stretch the urethra and compress the urethra, leading to narrow and elongated urethra. Okay, so narrow and elongated urethra, prostate is becoming bigger, so it will lead to sagging of the bladder. So the patient can have clinical feature. Lower urinary tract symptoms can be seen, which can be related to storage or voiding. That means the patient will have, what is that? The patient will have difficulty in urination. There is no flow will not be there. Okay, interrupted flow will be there. Okay, so clinical approach, first you are going to go for a distal rectal examination. So on the distal rectal examination, you can feel the enlarged prostate. Then you can go for USG KUBP, kidney, urethra, bladder, prostate. Okay, where we can use which one? We can check for the volume of the prostate, means how much size is the prostate, and most importantly, we can check for PVR, post void residue, means after urination, how much urine is present. We ask the patient to go for urination. After urination, small amount can be remaining. So if it is becoming more than 100 ml, it is a direct diagnosis of benign prostatic hyperplasia. Means more than 100 ml remains even after urination, then we will call it as benign prostatic hyperplasia. Okay, so we can go for cystometry, uroflowmetry, and PSA, prostate specific antigen. Okay, so actually prostate specific antigen, bachcho, the answers, it can be elevated in BPH, but it can be significantly elevated in the prostate cancer. Okay, so treatment, what is the treatment we are going to do? The treatment which we are going to do, my dear students, if the symptoms are mild, if there is no symptom, then medical management. What is the medical management for the mild of no symptom? Then you are going to use drug of choice is your 5-alpha reductase inhibitor, which is your, yes bacho, that is finasteride. Okay, finasteride is used for, what is that? That is used for the mild symptom. If at all there is a symptomatic treatment, my dear students, you are going to use a drug of choice, tamsulosin. Okay, symptoms of BPH plus hypertension is there, then you can go for prazosin. If prazosin is not in the option, you can go for doxazosin. If doxazosin is not in the option, alfuzosin. Okay, so symptomatic treatment is tamsulosin. tamsulosin. Okay, so if symptoms are severe, then we can go for holmium laser evaporation of the prostate or TURP. What is TURP? Transurethral resection of the prostate. Okay, so patient, while we are doing the surgery, if we use the normal saline, the patient can develop which syndrome? TUR syndrome. Okay, transurethral resection syndrome. To avoid this, we are going to use 1.5% glycine. Okay, so because TUR syndrome can include, so the complication of surgery can include, because of the TUR syndrome, patient can develop congestive cardiac failure because continuously irrigating the surgical field with a normal saline can lead to overload on the heart. That is one thing. Okay, then retrograde ejaculation is possible. Urinary incontinence, stricture, and hemorrhage are the complication of the surgery. Okay, so these are the topics which I wanted to discuss with you people specifically for the today's session. Okay, मुझे पता है सर आज के इस सेशन में कितने क्वेश्चन आएंगे, एटलीस्ट आई कैन गारंटी यू 3 to 4 क्वेश्चंस. ओके, क्योंकि आप लोगों ने, you guys would have studied the other chapters, I know that very well, so I know हमारा दिमाग कैसा काम करता है, maybe एक FMGE हो, so being that I understand, so wish you all a happy new year in advance, and I pray for all your success. So you should come out with a flying colors in your exam. Definitely, we pray for that on this New Year occasion. So see you people in the next slide. Bye bye and Happy New Year. No problem, no problem. So which zone in BPH? So usually remember posterior ones are involved in your cancer. Okay, BPH में तो सारे ही involved होते हैं. Zone number याद मत किया. Zone numbers will slightly confuse you because zone numbers are fact based thing जो पूछा नहीं जाता है, तो confuse मत कीजिए. Okay, thank you so much बच्चों. I hope I have made a difference in your urology discussion. I hope so. तो चलिए फिर हम भी थोड़ा बहुत न्यू ईयर मना लेंगे. ओके, हैप्पी न्यू ईयर, बाय बाय.